So, certainly there's a lot to consider here, and these are not small cases, and I think you need to build your sort of DA skill set to get to this point. But in an average week, I'm using these techniques, and I've learned from both of you how to do this, and it's greatly benefited my patients. So, I've learned a lot over the years. So questions, that come out of this, Stefan, you showed the collar on the stem, and you said you can impact the collar. Have you ever taken the collar off to improve access to the bone around the calcar, like with this extraction system you've mentioned?
The new extraction system from the Watson apparently also comes in a version where you can get around the collar, where you have a medial lateral plate and a medial anterior plate and a medial posterior plate, where you don't have to take out the collar. I guess there are titanium stems and you could cut off the collar. I've not done that.
Mm-hmm. And then what are you doing with the capsule? We've talked in this course about capsulotomy versus capsulectomy. So now we're dealing with a revision case. There's some scar tissue around the hip. Do you routinely open and then close it? Are you taking it every case? What are you doing, both of you? I'd like to know.
Yeah, I do a fairly extensive capsulectomy just for exposure purposes. Frequently, capsule is very scarred in, and it doesn't really serve that much of a purpose at that time.
I keep the capsule and use it as a retractor during the procedure, believe it or not. And so I agree, I'm not certain it makes a difference from a stability standpoint post-operatively, but I do keep it.
Yeah, my preference I do is aspiration. I'll open the skin. I have the tensor exposed. I put a needle in the joint. I'll take my first culture. I culture every revision. So I'll take a fluid sample. I open the case, and I will reflect the outer limbs of the capsule. The inner limbs I'll take as samples either for frozen section or for cultures as well. I usually send 2 tissue cultures and 1 fluid culture. So that's for me routine. I try to save the outer limbs of the capsule. That's what Chris and John Kege always taught about to improve some of the stability. So Ted, as a follow-up to your talk as well as Joel's talk about cages and triflanges, can you give us some tips if you have to face dealing with that, an anti-protrusor cage or a real triflange cage? What are some suggestions on how best to approach that case and get the exposure you need?
I don't. I've tried cup cage constructs, and I always felt that they, working, you can certainly bend the titanium plates that come with those, but for me, they always forced me into a more vertical acetabular component and into a version that I didn't want. And it seemed when I was doing these through posterior approaches, it seemed that they always forced me to retroverted. And when I was, in anterior approaches, they always seem to force you the opposite direction that you want. So I've moved more to that pelvic distraction technique. The impaction bone grafting is important with that, though. We use it true, looked up what they're doing, where they're getting good results in Europe. And so we take a couple femoral head allografts, we grind them up into 3 separate sizes of particulate component, and then mix all that together with antibiotics and impact it medially. And we don't use any mesh medially or anything like that. We impact it right against the internal organs of the pelvis, and it really seems to incorporate and work well. The Romans built roads that way, right? I mean, their roads lasted so much longer than previous civilizations because they used this particulate fill underneath the roadbed.
Right.
I think one of the main advantages for cages for the anterior approach is that because the patient is in the supine position, when you cement the cup into the cage, it's just easier to do. I mean, I remember doing cages with the posterior approach, and I don't know that I was ever really happy on how I cemented that liner in when I looked at the x-ray, because it's just so difficult to judge after a long revision where that pelvis is with a posterior approach. But with an anterior approach, you can bring in the C-arm. We know how to put in cups. We know what 20 degrees of anteversion is, what 40 degrees of inclination is, and so I just worry much less about stability and hardly ever have to use a constrained liner with a cage.
I agree, and Joel's point about the superior gluteal nerve, is really important when you're elevating the gluteus medius and minimus off the outer table of the ilium. If you have to do that because those tails on that cage are really long, if you're going from anterior to posterior, you're probably preserving both the nerve supply and the blood supply to that muscle. Whereas if you try and do that from posterior approaches, there's a limit to where you can go without compromising the nerve and blood supply to the muscle.
Plus, you have good access for the top 3 screws, and then you can percutaneously put in screws through the gluteus medius and minimus. for additional fixation.
Have either of you done the iliac crest osteotomy that Joel showed today?
I have not.
I've done iliac crest osteotomies for, combinations, acetabular fractures and total hips, but not for revisions.
All right. Well, thank you very much. We really enjoyed this session. I appreciate your contributions. To the audience, we're truly grateful for each of you coming to join us. I'll let Stefan make some closing remarks, and thank you all.